You see my screen?
Yes, we can.
Okay.
Also, Safwan, do you want the students to take just interrupt you during the lecture, or do you want them to write in chats, like just when they have any question?
I think it's okay if they can just write it in the chat, and then intermittently I'll just pause and see what's up.
Okay, okay, great.
Sounds good. Okay. All right. I hope everyone can hear me, and so I can start and see my screen. Okay. Everyone can hear me, right? Okay. Excellent.
Yes.
Perfect. Great. Assalamu alaikum.
My name is Safwan, fifth-year medical student, and I've been asked to give you a quick review on brain edema and intracranial pressure. It's a very important topic, and I'll try to make it as simple as possible, tell you what you really need to know from the scope of this particular lecture that you have. And so let's start. One second. Okay. So I wanted to start off the lecture by giving you this very basic thing. I'm sorry, just give me 1 second. I need to hide this thing from the top. Okay, perfect. So I wanted to give you this overview of how things look like on different modalities on an MRI. Okay, because for when you talk about the central nervous system, the MRI is one of the most important imaging modalities. So I'll give you a very quick and easy way to remember stuff. If you guys can, I know you guys should know by now what is the gray matter and the white matter. Just to review quickly, the gray matter is basically the cell bodies of the neurons, and the white matter is the myelinated axons of those neurons, right? So if you look at the brain, we have the gray matter and the white matter. Okay. So in T1 weighted images, when we say T1, it's going to appear exactly like that. So if you look at the gray matter, look at the gray matter on the outside, it's going to appear gray, and the white matter is going to appear white. Can you guys appreciate the difference between gray and white here? It's clear, right? So we have the gray here and the white here. Okay. And of course, on T1, CSF is black. So where would you find CSF? You find CSF in the ventricles, and the ventricles here are dark or black, which means CSF is black. So this is T1. All right. Now, when we talk about T2, you flip everything. All right. So the gray matter is going to appear white, and the white matter is going to appear gray. Look at this here. You see this white matter? See this white strip? That's basically your gray matter, but it's appearing white in T2. Okay. And the gray matter, which is supposed to be and the white matter, which is supposed to be white, is appearing darker on T2 images. And CSF is also white instead of black. And flare is the exact same thing as T2, except the CSF is made to be appearing darker. Okay. T1, gray matter is gray, white matter is white, and CSF is black. In T2, gray matter is white matter is gray, and CSF is white. In flare images, is the exact same thing as T2, but the only difference is that CSF is black here. Is everything clear so far? Okay, perfect. Let's move on. Right, so basically what we're talking about here is brain edema, right? So let's define brain edema. Edema, generally speaking, is excessive accumulation of extracellular fluid, and it will lead to an increase in intracranial pressure. Why does it lead to increase in intracranial pressure? Because, well, if you have fluid inside a closed vault, which is your skull, it's going to lead to a raised pressure because it cannot really accommodate too much of fluid. So it's going to lead to a rise in intracranial pressure. And because you're compressing on those neurons and axons, your neural function is going to be impaired, and actually brain edema can actually lead to death. Okay, so it's at sometimes it can prove to be an emergency. Right. So generally speaking, when we talk about edema, we can classify it broadly into two categories. Okay, number one is something called a vasogenic edema, and number two is cytotoxic edema. And if you just look at their names, it's simple enough to understand that vasogenic edema has something to do with the vessels, or the vaso or the vessels, and cytotoxic has something to do with the cells, right? Or abnormalities in the cells. So if you look at vasogenic edema, it is the extracellular fluid accumulation in the brain parenchyma because of the disruption of the blood-brain barrier. Here, there's an image of the blood-brain barrier. If you look at the blood-brain barrier, this is your blood vessel. This is your smallest blood vessel, which is your capillary, okay? And then we have the astrocytes. The blood-brain barrier is formed by these two main things: the tight junctions between your endothelial cells of your blood vessels, of your capillaries, and the astrocyte foot processes, which cover any holes that might be between the capillary pores. Okay, so two things form your BBB. Number one is your tight junctions between your endothelial cells, and number two is your astrocyte foot processes. So vasogenic edema is basically that you will disrupt this blood-brain barrier because of any reason. We'll talk about some of the etiologies in a bit, but basically this tight junction is gone, these foot processes are gone, and so all of the fluid, including the proteins, are going to leak out into the brain interstitium. Okay, and that is called vasogenic edema because it's happening because of a problem in the blood vessels. Next is cytotoxic edema because it has something to do with toxicity or abnormalities of the cyto or cells. Okay, so it is caused by intracellular accumulation of fluid, and I'll talk about the pathogenesis after a while because it's a little kind of specific. All right, so what can cause vasogenic edema? Head trauma can cause vasogenic edema because, well, head trauma can lead to disruptions of the blood vessels and hence the BBB, and it can cause vasogenic edema. Tumor, can anyone type in the chat really quickly, why would a tumor cause vasogenic edema? Excellent. Very good, Tariq Makhzoom. It's about angiogenesis. When we talk about a tumor causes angiogenesis, new blood vessels to be formed, which feeds the tumor. Now, the tumor which forms the new blood vessel is not very good at it. The blood vessels that it forms are very leaky. So the BBB is not very efficient in the new blood vessels formed by a tumor, and hence that leads to also vasogenic edema. Abscess can also lead to vasogenic edema, and that is because of inflammation, as Sarah has said, but that's mainly for abscesses. Okay, inflammation, when there's inflammation, there's release of histamine. Histamine, as you know, causes increase in vascular permeability by loosening those endothelial junctions and causing vasogenic edema. Malignant hypertension. Malignant hypertension is basically hypertension that is extremely severe. Okay. And if the blood pressure is extremely high, it can also disrupt the blood-brain barrier. Correct. The blood-brain barrier is not well developed for these tumor cells, and hence it leads to vasogenic edema. Infections cause inflammation, and inflammation causes edema, and specifically vasogenic edema. High altitude cerebral edema. When you go to altitude, basically the carbon dioxide is going to decrease in the high altitudes, and that if you decrease your carbon dioxide, I don't know if you guys took this specifically, but that has something to do with the cerebral perfusion pressure, or cerebral blood flow. If you decrease the carbon dioxide, it may have an effect on the cerebral blood flow, and that can eventually lead to cerebral edema, and that is specifically the vasogenic edema. Okay. Okay, second. All right, so this is basically the pathogenesis of the vasogenic edema that I have mentioned. It's about the disruption of the blood-brain barrier because of inflammation, toxic agents, abnormal capillaries, and when the proteins leak into the interstitium, that cause swelling. Remember that proteins cause oncotic pressure, and oncotic pressure is going to draw more fluid into the interstitium. Okay. And if you have obviously the plasma filtrate accumulating in the interstitium, that is going to alter the ionic balance. I will go back to this because I believe I misspoke. Yes, you're right, Jude. Basically, at high altitudes, your carbon dioxide levels are high. Sorry, yes, your carbon dioxide levels are high. If you have high carbon dioxide levels, that causes vasodilation in your brain vessels. And if you have too much vasodilation, you have too much cerebral blood flow, that is going to lead to cerebral edema. Okay. This is basically the pathogenesis of vasogenic edema. Look at these tight junctions here. They're no more present, and there's extravasation of fluid. Okay. And all of this can lead to that. So everything is clear up till now. Any questions? Okay. Right. So here we come to our MRI images. And basically here the doctor is trying to tell you how does vasogenic edema looks like on the MRI. You know, if I'm very honest with you, this is a little above your level, but if he's included this in the slide, then it must be a little important, but it's not very important, you know, just to tell you. So this is an MRI. This is T1. Why is this T1? Because the CSF is black. Enhanced, which means this is you're using contrast here. How can you tell that? You see these blood vessels, they're all filled with contrast fluid. That's why they're appearing white. So this is T1 contrast with gadolinium contrast. And as you can see here, it seems like from the picture, it says this is metastasis. And around the metastasis, you can see this faint sort of hue of fluid, and that edema because of biology. So you should be identify it. Okay, right. I'll just really quickly repeat. If there is a lesion or if there's an abnormality in the brain, like here, there's a metastasis from a tumor, and here there's an abscess. Okay, we all know that these are some of the conditions in which edema can form, vasogenic edema. And here it shows up as exactly that. You can see this hue of abnormality around the lesion, which shows up as different intensities or different sequences of MRI. Okay, so here, if it's T1, it'll show as high, you know, this is this right here on at the very around the lesion, that's your edema right here. Okay, which is hypointense, which is less intensity, a little darker. But if you give it flare, it's going to light up, and it shows you as a light, it shows you as something that's white. Okay, so generally speaking, whenever you think of T2 or flare, any abnormality on T2 or flare is going to appear white as a rule of thumb. Okay, doesn't always apply, but generally speaking, that's how it goes. So the same applies here. Here, the edema is a little bit black, and same applies here. See, the edema is a little bit black. The lesion itself is white, but if you look at the edema, it's a little black on T1. But if you switch it to flare or T2, flare and T2 are the same thing, as you know, it's going to appear white. Okay, so is this clear so far? These are just MRI images that are showing you how edema looks like, and they're not, in my opinion, I don't think they're extremely high yield. Clear? Okay, let's move on. Now we talk about cytotoxic edema. Cytotoxic edema, as the name suggests, has something to do with the cells. It's an intracellular phenomenon. Now, let me tell you quickly about the pathogenesis of cytotoxic edema. It's very simple. I want you to just remember these few words. Number one thing that happens is that there's a cellular injury. This could be because of hypoxia. This could be because of a toxin or whatever. There's a cellular injury. The neurons are injured. Okay. Next thing that happens is that when the cell is injured, it's not able to perform metabolic activities, which means it is not able to produce enough ATP. Okay, now there are important pumps in the cell membranes of these cells that require ATP, such as the sodium potassium ATPase pump, right? And if that sodium potassium ATPase pump is not able to function properly because of low ATP levels, then it stops working. If it stops working, there's going to be ionic imbalance. Okay, so for instance, let's talk about the sodium potassium ATPase pump. What does it do? It pumps out sodium and it takes in potassium, right? So if the pump stops working, then all the sodium is going to accumulate inside the cells. what attracts sodium? What is attracted by sodium? Water. And so water is going to follow inside the cell, and the cell will swell up, causing the cytotoxic edema. Okay, is this clear? Okay. So here the doctor is basically showing you the exact same thing that I've mentioned here. Look at this. There is injury because of ATP depletion, mitochondrial dysfunction, oxidative stress. All of this leads to less ATP production and less function of these pumps, which means there's an ionic imbalance. Mainly speaking, sodium accumulates inside the cell, and it's going to cause water accumulation, fluid accumulation inside the cell. Here they've shown that astrocytes are swelling, but even neural cells can also swell. Okay. Now, here's something that is quite important. Okay. When you talk about cytotoxic edema, there's nothing wrong with the tight junctions of the blood vessels. Can you see is there anything wrong in the tight junctions? No, they're still there, which means that there is no change in vascular permeability when it comes to cytotoxic edema, because things are happening at a cellular level, not at a vascular level. Is that clear? Okay, perfect. Now, why is this happening? And why is this outflow of intravascular sodium and fluid? Can someone try and explain based on the pathophysiology that I've mentioned? Let me repeat the whole thing. Okay. First of all, what happens in cytotoxic edema? There's a cellular injury. Let's say that there is hypoxia. The patient has a stroke, no blood flow, no oxygen. Now, if there's hypoxia, the cell is injured. The cell is not able to produce ATP. If you guys remember from biochemistry in first year, oxygen is very important for cells to make ATP via oxidative phosphorylation, right? So if there's no oxygen, there is no ATP, or there's very, very little ATP. Now, if there's very little ATP, then things in the cells that require that ATP are not functioning. And when we talk about cytotoxic edema, the most important thing is the sodium potassium ATPase pump. Okay. Now, if the sodium potassium ATPase pump is not working, this means that it's not able to pump out sodium and pump in potassium, right? Now, if that happens, this means that all the sodium that was supposed to be pumped out by the sodium potassium ATPase is accumulating inside the cells. All right. And all the potassium is outside, which means that sodium is accumulating inside the cell, and sodium, as you guys remember from renal physiology, attracts a lot of water. It's mainly sodium that attracts water, not potassium, not chloride, not whatever. It's mainly sodium. So if you have sodium, a lot of sodium inside the cell, water is going to come in and is going to accumulate and cause swelling of the cell. It could be astrocytes, it could be neurons. Now, is that clear? Okay, now I'm going to check the answers for what happens here. Yes, exactly. This is basically kind of what's happening here. Okay. Because there's an ionic imbalance in the cells, there's an ionic imbalance in the interstitium. Okay. If there's an ionic imbalance in the interstitium, it's going to cause different ions to flow from the blood vessel outside and inside. Okay. This is called ionic edema. So remember, think of it like this. Okay. If we have sodium accumulating inside the cells because of the failure of sodium potassium ATPase, we have less sodium outside the cell. If we have less sodium outside the cell, how are we going to get the sodium? We get it from the blood vessel. So sodium diffuses from the blood vessels into the interstitium, and so water will also follow then, and that is called ionic edema. Basically, the ions are, attracting the water and causing edema. Is this clear? That is correct. Ionic edema can happen even when the blood vessel is normal. It does not require the disruption of the BBB. Clear? Okay, very good. Okay, now let's talk about some of the pathophysiology, some of the etiologies of cytotoxic edema. Think of anything that causes injury to this cell. Cerebral ischemia, because of a stroke, because of hypotension, because of blood loss. Hemorrhage, also blood loss, causes hypotension. If there's low blood pressure, there's not enough blood pressure to perfuse the brain, which means the brain is not supplied with enough oxygen, and hence we get injury to the cell, leading to cytotoxic edema. Liver failure can cause cytotoxic edema as well, because of abnormalities with ammonia. The example that's given here is called Rye syndrome. Does anyone know when we get Rye syndrome? Check the chat. No, tight junctions are not affected in ionic edema. Okay. Okay, Rye syndrome, basically, I tell you what Rye syndrome is. Okay. I think it's very important, but just to complete the thing, Rye syndrome is basically something that happens in childhood. Okay, this is what happens if you give children aspirin. You're not supposed to give children aspirin, but if you give children aspirin, they get something called syndrome. Now, Rye syndrome, the pathophysiology of Rye syndrome is a little complex, but it has something to do with mitochondrial dysfunction. And if you know that mitochondria are very important for making ATP, you can infer that if we have mitochondrial dysfunction in Rye syndrome, we will have cellular injury and hence cytotoxic edema. Is that clear? Yes, you do get jaundice in Rye syndrome. Okay. Right. Then there's severe hypothermia. Severe hypothermia can cause low perfusion pressure. It can cause hypotension. It can cause activation of parasympathetic system and multiple mechanisms that can lead to hypoxia and hence cytotoxic edema. Okay. Cardiac arrest, which means the electrical activity in the heart is not working anymore, which means that heart is not able to pump any more blood, which means that the brain will not be supplied with enough blood and hence not supplied with enough oxygen. All right, is everything clear so far? Please ask me any questions. Hypothermia can also cause hypoxia. I'm not exactly sure of the exact pathophysiology of it, and you will not be asked about it. So just remember, hypothermia can lead to hypoxia because of multiple mechanisms. Okay. All right. Okay, I forgot to tell you the things about the images. You can see here that I'm not sure what you can see here, honestly, to be honest. This might be a blood vessel that is blocked. That can lead to, did he tell you what this is? This image is exactly? It might be a blood vessel that's blocked, that is leading to a stroke, which can lead to hypoxia. Okay. But there's better way of seeing blood vessels than on a CT scan. Okay, right. MRI in cytotoxic edema. And again, I do not think that this is extremely important for you guys, okay? But just know this, okay? In T2 imaging, the signal intensity is increased, okay? And in DW images, DWI or diffusion weighted images, the signal intensity increase. Whenever you say, when you talk about, okay, let me give you this something basics again, okay. When we talk about the MRI, anything that is white, we call it hyper intense or increased in signal intensity. When something is darker, we call it low signal intensity or hypo intense. This is for MRI, okay. When we talk about CT scans, we can say if something is white, we call it hyper dense. When something is dark, we call it hypo dense. So intense is for MRI and dense is for CT scan. That's why it's all about intensity here. Just know that on a DWI or diffusion weighted images, there's increased signal intensity because of cytotoxic edema. And actually DWI imaging is one of the earliest imaging that can detect a stroke, okay? Other types of imaging take longer to detect a stroke, okay? So is this clear so far? I do not think that this slide is very important. Okay, Yasmin, what exactly do you want me to repeat? Yes, so yes, edema is white on T1 and also T2. Pretty much, honestly, yes. If there's edema, you will see it as hyper intense on T2 and flare, and also DWI. I think that should be good enough to know. DWI is a type of MRI. It's called diffusion weighted imaging. It's I think it's a little advanced for you guys to understand how it works, unless you took it in radiology. It's a type of imaging, basically. It's a type of MRI. It's a very special sequence of MRI. It can detect strokes very early on. Okay, more cytotoxic signs in MRI. So see, this is T2. Why is it T2? Because gray matter is white matter is gray, CSF is white. That's why this is T2. And you can see some edema signs here. Like, see this here, hyperintense area. This is edema, okay? You do not have to know how to differentiate cytotoxic and vasogenic edema on MRI, okay? I, as a fifth-year medical student, don't have to know how to do that. This is diffusion-weighted images, which also show you this hyperintense lesion, hyperintensity, which is consistent with edema. ADC is another sequence of MRI, and in ADC, actually, from what I see here, it's hypointense, which means it becomes darker, basically. Reduced ADC values. Again, I think this is a little too advanced for you guys. You have to focus on basically the pathophysiology of vasogenic and cytotoxic edema. You have to focus on the etiologies of vasogenic and cytotoxic edema, and then you have to focus on the consequences, which we're going to talk about in a bit. So everything is clear so far? Okay. Focus really on the high yield stuff. Are you guys taking radiology with Dr. I forgot his name. Are you taking radiology and neuroradiology? No? Okay. So no one came and gave you a lecture on MRI and CT scans of the brain? It's not included in the exam. Okay, great. Great. Khalas, then I don't think they'll give you many MRIs in the exam. But just for now, no, for the purpose of this lecture here, just know that edema is white on T2 and flare, and also DWI. Okay, right. So here, the doctor is basically saying that, you know, there's no circumstance in which only cytotoxic or only vasogenic happens. Usually, what happens is both. Okay, it's a combination of both, but sometimes one of them is obviously predominant over the other. Now, here he has mentioned kind of an important point. If the swelling or if the edema is because of a vasogenic cause, one can give mannitol to draw the fluid into the vascular bed. Okay, this takes us back to pathophysiology. What is the pathophysiology of vasogenic edema? It has to do with the blood vessels, right? Increased permeability of the blood vessel. Now, if I give this patient mannitol is a sugar, right? If I give this patient mannitol, the mannitol is going to accumulate in the blood vessel. It does not leave the blood vessel. If the mannitol accumulates in the blood vessel, it is very it's something that attracts water. So it's going to attract all the water from the interstitium into the blood vessel, reducing the edema. And that's how we treat high intracranial pressure. That's how we treat edema. We can give IV mannitol. Why IV, not oral? Because it has to be inside the blood vessel. And once it's inside the blood vessel, it stays inside the blood vessel and attracts all the water from the interstitium into the blood vessel and reducing the effect of the edema. Is that clear? I don't know. I can draw on this thing. Okay, great. All right, there are other types of edema that the doctor has mentioned. There is interstitial edema, there is osmotic edema, and there is mixed edema. Let's talk a little bit about interstitial edema because he has elaborated on it, but we'll just quickly go over osmotic edema right now and skip it altogether. It's just because there's high osmolality in the brain, which causes accumulation, which causes attraction of water into the brain, causing edema. That's it. Water intoxication can lead to that. Water intoxication is kind of a complex topic. This is something that has to do a little bit with renal physiology. But just remember, if you take if you drink a lot of water, what happens to the osmolality of your serum, of your blood? Decreases, right? If you have too much water and not enough salt, the osmolality decreases. And when we talk about relative terms, the osmolality in the brain is going to be higher, and so it's going to attract all that water inside the brain and causing edema. Is that clear? Is osmotic edema clear? Okay, great. Now let's talk a little bit about interstitial edema, okay? Honestly, it seems very similar to vasogenic. I will explain to you before, I will explain to you now. So these are the two barriers that we have inside the brain, okay? We have the blood-brain barrier. We have the blood-brain barrier, which is between the brain parenchyma and the blood vessel, and we know what forms that. And then we have the blood CSF barrier, which is formed basically here by the choroid plexus. Here we have the choroid capillary membrane, which is your endothelial vessels, and this is what forms the blood CSF barrier. Okay, and it also has tie junctions, which contribute to the formation of the barrier. Now, what happens in interstitial edema is that we have a lot of CSF. Okay, if you see in this image, can anyone tell me what sequence of MRI this is, just for fun? I cannot see the chat. Once again, yes, excellent. This is T2. Very good. So if you see here, what ventricle is this? This is the lateral ventricle, right? Is the lateral ventricle, and you can see it's huge. This is not supposed to be this huge. If you see normal images, lateral ventricles are small. And so this is a lot of CSF accumulation because of whatever reason. Okay, it could be because of Arnold-Chiari malformation, it could be because of infection, it could be because of a tumor. Whatever the reason is causing the CSF to accumulate, this is what the ventricles are appearing to be as. So what happens if you have too much CSF? That is going to damage the blood CSF barrier. Now, if you damage the blood CSF barrier, blood will leak from the choroid capillary blood vessel into the brain parenchyma, which is around, it's going to be around here. Okay, so this is what he's shown in this image here. This image right here, for instance, if you see this is a CT scan, so it's not very clear here, but if you see this lateral ventricle, you see this hypodense area around the lateral ventricle, that's your edema. It's much better to be seen on FLAIR or T2, lateral ventricle, and you see the hyper intense areas around the lateral ventricle, and they're only around the lateral ventricle because that's where the blood CSF barrier is damaged, and so the edema will accumulate only around the ventricle. Is that clear? Interstitial edema, it's just a disruption of the blood CSF barrier, very similar to vasogenic edema. Okay. Clear. Okay, excellent. Is this FLAIR or T2 while CSF is black? Yeah, so this is T2 on the right side right here. Can you guys see my cursor, by the way? Okay, great. So yes, this is T2. As I told you, T2 and FLAIR are exactly the same thing. The only difference is that CSF is black on FLAIR. Okay, and this is one of the reasons it's black on FLAIR. Imagine if this was T2, you would see white ventricles, right? Just you see white ventricles and you will see white edema. So it's very hard to differentiate between the two. So what do? We make the CSF black, and so we can easily differentiate what is actually abnormal and what is actually CSF. That's why they use FLAIR. Is this clear, Jude? Okay. Tariq is asking, does it present with ventriculomegaly? Ventriculomegaly is kind of, you can say, is a factor that leads to interstitial edema. Okay, so first you have, let's say, obstruction wherever in the brain that leads to ventriculomegaly. Ventriculomegaly will lead to the interstitial edema because of disruption of the blood CSF barrier. Okay, it's not the other way around. Is that clear, Tariq? Okay, great. Okay, let's move on. So I added this image, by the way. It's from Google, right? So what? So I mean, logically thinking, what is going to happen if I have a lot of edema? Okay, if I have a lot of edema, if I have a lot of, what's the intracranial pressure, by the way? Do you guys know what's the ICP? Yes, obstructive hydrocephalus can cause it. Yes. So what's the ICP? ICP is intracranial pressure. It's basically the pressure because of CSF, because of all the things that are present inside your skull, you know, and inside your cranium that contribute to the formation of the intracranial pressure. Okay. Now, if you have edema, which means accumulation of blood inside the brain parenchyma, that is going to increase the intracranial pressure, right? So that is one of the main consequences of brain edema. Now, really, it's the increased intracranial pressure that leads to every other consequence of brain edema that you see on this slide right here. Okay. Reduction of cerebral blood flow. Why do you think that is? I think I added an image. I just want to find it first so I can show it to you right now itself. Okay, it's not here. Okay, it's okay. So I want you to imagine that there's a blood vessel, right? There's a blood vessel and there is intracranial pressure around it. I can draw it, wait. Okay, so let's say that there's a blood vessel, right? Inside the brain, and around it is the brain. So the pressure exerted by the blood in the blood vessel is called what? It's called the arterial pressure, right? It's called the mean arterial pressure. So there's a pressure from the blood vessel. Now there's a pressure on the blood vessel from the surrounding structures in the brain, and that is the intracranial pressure, right? So this is the intracranial pressure. Okay. Now, in order for this blood vessel to be patent, for it to have blood flow, the pressure inside the blood vessel must be at least greater than the intracranial pressure, right? But if you have too high intracranial pressure, it can shut this blood vessel and prevent any cerebral blood flow. So is this clear? This is why you have reduction of cerebral blood flow, because of high intracranial pressure. Now, if you have reduction in cerebral blood flow, what happens? You get hypoxia, okay? Less oxygen delivery to the tissue. The increased intracranial pressure is going to reduce the cerebral blood flow because it causes almost, you can think of it as compression on the blood vessel, okay? Yes, Sarah, when ICP is equals to mean arterial pressure, blood flow stops. And we will discuss this later on. Hypoxia, irreversible impairment of neuronal function because of the hypoxia, okay? Pressure on the cerebral tissue can lead to herniation. We'll talk about herniation, and it can lead to death, okay? Certain types of herniation can lead to death as well. We'll talk about that. So here is some of the effects of the edema on the CNS that the doctor has explained. Increase in tissue mass from the excess accumulation of body fluid in the brain. Now, this is a problem because the brain, as you know, is a closed space. And so any edema, any extra fluid is going to cause an increased intracranial pressure and have all the detrimental effects that we said before. In addition to that, the brain lacks lymphatics. The function of the lymphatics is to take away the excess extracellular fluid, right? And if you don't have lymphatics, all the extra edema that's inside the brain cannot be taken away. And so it keeps on increasing the intracranial pressure until it can stop the blood flow, it can cause hypoxia, it can cause herniation, okay? This is basically what the doctor has said, what is inside the cranium, okay? There's not a lot of things and there's not a lot of space to expand is basically what he's trying to say here. Now, this is very important, okay? Clinical hallmarks of raised intracranial pressure. This is what you'll be recognizing on your questions stems, right? This is a patient who will come in with a headache, with vomiting, with papilledema, okay? Swelling of the optic discs, we'll discuss that later on. So these are some of the hallmarks of increased intracranial pressure. So when you think of headache, vomiting, papilledema, you start to think of, increased intracranial pressure, and you start to think of etiologies such as, well, brain tumor, abscess, could even be a stroke, could be hydrocephalus. All that can lead to raised intracranial pressure and lead to headache. Why headache? Because, well, it's going to, high intracranial pressure is going to disturb the meninges, it's going to irritate the meninges, and the meninges are supplied by sensory neurons, and that's why it causes the headache. Vomiting, well, the vomiting center has a lot of inputs that are too advanced for anyone to know at this level, but one of those inputs can cause the vomiting center in the medulla to be activated and cause, well, vomiting. Papilledema, we'll talk about papilledema in a bit. So these are the hallmarks of ICP, and this is what you should be able to recognize on your question stems. These are the components of the brain. Mostly it's made up of brain tissue, then intravascular blood makes up 12%, and CSF makes about 10%. Same thing is illustrated here. So as I said before, the brain is a closed space and lacks lymphatics. So it has to, move things around, adjust things around if there is increased intracranial pressure because of any reason, okay? So the volume from one component is displaced but the total volume will not change. Basically, it's just trying to, this slide is trying to say that the increased intracranial pressure is tried to be accommodated for inside the brain by shifting of structures. Okay, but there comes a point where that cannot happen anymore, and this is when all the detrimental effects start to take place. So here, for instance, if you look at the intracranial volume right here, the intracranial, you might try to increase the intracranial volume, right? But the intracranial pressure does not change by much. See how the line is almost, line A is horizontal, صح? Which means I can add a tumor, I can add vasogenic edema, I can add cytotoxic edema. I'm increasing the volume because of the edema, but I'm not changing much of the intracranial pressure because of some of the auto-regulatory mechanisms that are present inside the brain. Okay, so this is why the ICP remains constant for some amount of volume. But after that, I can start to add another brain tumor, more metastasis, more edema, and then, you know, there reaches a point where we call the critical volume, after which the ICP starts to shoot right up. Okay, this is basically just trying to tell you that. Yes, this is why herniation happened. Can you explain how stroke causes edema? Well, okay. What happens after a stroke, Sarah? A stroke causes hypoxia, right? If a stroke causes hypoxia, hypoxia will lead to less oxygen delivery to the cells in the brain, less ATP, and causes cytotoxic edema. Okay? Clear? Let's move on. Right, now we come to actually talk about ICP, intracranial pressure. And normal ICP is around 15 to 20 centimeters of water. You measure it with, when you're doing a lumbar puncture with a manometer. And usually it's 15 to 20 centimeters of water, okay? Now, high ICP can be because of all of the factors that we have discussed before. It can be because of edema. It could be because of the tumor, and the tumor may not actually be causing edema. You know, just because of the fact that there is a tumor there, that can lead to high intracranial pressure. Excessive CSF, CSF is produced from, let's say, the choroid plexus, right? You guys, I hope you guys know that. Sometimes we can get these tumors of the choroid plexus that overproduce CSF, or we can have blockage of CSF absorption. So there's excess CSF inside the ventricular system. And all of that also leads to increased intracranial pressure. Hemorrhage, there's blood accumulating inside the brain parenchyma, causes increased ICP. Is this clear? Some of the factors, some of the causes of increased ICP. So I just want to, elaborate on the fact that a tumor might be growing. This is just a ball of cells, of extra abnormal cells, and it may not be causing edema. Okay, but it's still causing increased intracranial pressure just because of this is an extra ball of cells inside a closed vault that is not supposed to be there. This is why it increases the volume until it reaches a critical point, after which the pressure also starts to increase. Is everything making sense so far? Okay. Right. So here the doctor has, elaborated on the progression of increased intracranial pressure, the steps that take place. Let me just go over it. It's very simple. It makes perfect sense. Okay. So when let's go here. When we are in stage A, right here, when we're still in the initial stages of increasing intracranial volume and there's not much change in increased intracranial pressure, this means that we're accommodating for it. Okay. How are we accommodating for it? We're doing this. We are displacing stuff around. We're moving stuff around, and mostly CSF, to make sure that we accommodate for this increased volume. So making sure that the pressure doesn't increase. Okay, it's the pressure that's the main thing that causes the problems, not the volume. It's the pressure. Okay, so we can have lots of volume, but if the pressure is not increasing, the brain is accommodating. But if the pressure starts to increase, this is when all the problems start to happen. Okay, now if the ICP is still high, the cerebral blood volume is altered. As I told you, right? There's going to be vasoconstriction and also external compression of the blood vessel. And so that affects the blood flow to the brain. Okay. Then we can come to stage 2. The ICP is continuing to rise, and now the brain's ability to adjust are exceeded. The brain cannot adjust anymore, right? So the ICP starts to increase, and this causes hypoxia because of the reduced blood flow, as I've mentioned, because of the compression effect. Now, because your ICP is increasing, right, you get cerebral ischemia. Now, cerebral ischemia activates the sympathetic nervous system. Okay, it's a accommodative mechanism. Sympathetic nervous system is activated, and that causes systemic vasoconstriction. So vasoconstriction around the body, not just inside the brain. Why does that occur? Because we want the blood pressure to be high, so we can supply the blood vessels in the brain. Let me just draw it again, just to explain you that fact again. So let's say this is the blood vessel, right? And here we have the mean arterial pressure. Okay. And here we have the ICP. Now here, let's say the ICP is huge, lots of ICP, which means the blood vessel is not patent enough, is not supplying enough blood. The cerebral blood flow is very low, okay? So what the brain does is it activates the sympathetic nervous system to cause increased blood pressure, which means it increases the MAP, or mean arterial pressure. It increases the pressure inside the blood vessel by vasoconstriction in the systemic circulation. This tries to increase the pressure inside the blood vessel to counteract this high ICP, so the cerebral blood flow can increase. Okay, so this is basically this point right here. Okay, so here we can start to have, some symptoms. In stage 2 of ICP, we can start to have symptoms: confusion, restlessness, drowsiness, and breathing changes. I will talk about the breathing changes and the Cushing reflex and the Cushing triad, in the very end. These are just simple stages. Okay. Now here in stage 3, this is where the ICP begins to approach the mean arterial pressure. This is where the stuff starts to decompensate. Why? Because now the cerebral blood flow is not enough. Okay. Okay. What part do you want me to repeat exactly? Okay. No. Okay. So. Okay, let's start from stage 1 again. Clear. In stage 1 of ICP, there's accommodation happening. Okay, there's still some problems happening with the vascular system of the brain, but still the brain is compensating. So there are no or very few symptoms. Okay, is this clear? There's in stage 1, just remember it's asymptomatic because the brain is accommodating. That's all you need to know. Let's go to stage 2. Now in stage 2, what happens? ICP is still rising. The brain is not accommodating anymore. So what happens is that this happens. Blood vessel, mean arterial pressure is not enough to perfuse the brain. Okay. Okay, this is the ICP. ICP is really big, really high, which means the arterial pressure is not enough to overcome the ICP. I'll give you a formula. CPP. You don't have to know this unless you have talked about this in another lecture, but CPP is equals to MAP. Sorry about this. I'm typing with the touchpad. Minus ICP. ICP. This is basic physiology, by the way. The perfusion pressure of the brain is the mean arterial pressure, the pressure inside the blood vessel, minus the intracranial pressure, or the pressure that is pushed on the blood vessel by the cranial contents. Okay, and this makes sense, right? If the mean arterial pressure is high, the blood can go across. If the mean arterial pressure is very low or ICP is very high, the blood cannot go across because the CPP will become 0 or negative. So what happens is that the brain activates the sympathetic nervous system. You know what happens when you activate the sympathetic nervous system? You have systemic vasoconstriction. If you have systemic vasoconstriction, what happens? Your blood pressure increases, right? That is the main thing of sympathetic nervous activation, right? Your heart rate increases, your blood pressure increases. Now, if your blood pressure increases, then your blood pressure or your mean arterial pressure starts to increase, right? So this value right here starts to increase. Now, if MAP starts to increase, it starts to overcome the ICP. So brain is still trying to accommodate, to keep the CPP in a positive range. Okay. So yeah. Second, please. Okay. So this is why the systemic vasoconstriction happens and the sympathetic nervous system activation happens. Yes, there is some aspect of a little bit of decreased blood flow, but it's not enough to cause the symptoms. Okay. Systemic vasoconstriction, exactly as Huda has said. In stage 1, the brain tries to compensate by vasoconstriction. Now, here the doctor has mentioned that there is vasoconstriction happening, but this is the brain is trying to do this to reduce the blood flow a little bit, so the blood doesn't bring a lot of fluid. Okay, so to decrease the edema, basically. But still, the brain is compensating in stage 1. But in stage 2, brain is still compensating a little bit by increasing the blood pressure, mean arterial pressure, to keep perfusing the brain, but it starts to become symptomatic, but transiently symptomatic. Okay, some intermittent symptoms of confusion, restlessness, drowsiness. Yes, the cerebral ischemia is what causes the activation of the sympathetic nervous system. That is correct. Okay, then we have stage 3, where the brain is not able to more, which means the blood pressure that the brain tried to increase with the sympathetic nervous system activation or whatever the brain tried to do, it's not working anymore, which means the mean arterial pressure, it starts to equal the ICP. And as you know, CPP is equals to MCP, MAP minus ICP. I'm just going to write this in the chat. CPP is equals to MAP minus ICP. And this is just basic math and physiology. If your MAP if your ICP is way too high, which means your cerebral perfusion pressure is not good enough, which means you start to get hypoxia and hypercapnia. Hypercapnia, I need too much carbon dioxide. Now, all of these can lead to further edema. So it becomes almost like a vicious cycle, right? So we already had edema before probably, but now we're having more edema because of the hypoxia. And what type of edema do we have? We get cytotoxic edema because of the low ATP. Okay, and these are all the manifestations. You have decreased levels of arousal. Okay, so the reticular activating system in the brainstem is not, it's inactive, which means patient starts to lose consciousness. There's a widened pulse pressure. Okay, Cheyne-Stokes respiration, which is abnormal type of respiration. Just know this is abnormal types of respiration. Bradycardia, because of the increased pressure in the carotid arteries, as you know, that will cause basically the activation of the parasympathetic nervous system to decrease the heart rate. If you remember from cardiovascular physiology, if there is something in the carotid arteries, we have the carotid baroreceptors, right? If you have too much blood pressure, then if you have really high blood pressure, that is going to cause bradycardia because of the activation of the parasympathetic nervous system. Don't worry, I'll talk about the bradycardia, I will talk about the hypertension, I will talk about the abnormal respirations in the very end. It's called the Cushing's triad. I'll explain completely in the end. Pupils small and sluggish. Why? Because have you guys taken what controls the pupil size? Which nerve controls the pupil size? Cranial nerve. 1, 2, yes, exactly. Very good thought. Cranial nerve number 3. And so if you have too high intracranial pressure, the cranial nerve number 3 starts to be compressed, and a decreased function of the cranial nerve number 3 causes the pupils to become small and sluggishly reactive to light. Okay, that is where you require surgical or medical intervention. This is not very, I don't believe that intervention is very important in your in second year. Right, now this is khalas. This is the end stage, I believe so. The perfusion pressure is extremely low. Okay, severe hypoxia, acidosis. Okay, why acidosis? Because of the brain tries to do anaerobic respiration and forms lactic acid and forms acid and causes acidosis, right? And this is where the herniation can happen. Now, I will talk about herniation in a bit. Intervention is good. Oh, great. Okay, and the blood flow is severely reduced. I explained all of this in the 2 slides earlier on. So this is just really the last stage. Nothing can happen now, and it's really severe. Okay, so this is what I talked to you about. Remember this: ICP and MAP. The ICP is too high, then the MAP, then the brain can no longer receive enough oxygen because of the compression of the blood vessels. This is how you should think of it. Okay, I will talk about this part. hemorrhages develop in the brainstem, pupil dilation and fixed. I explained to you why this happens, progressing to bilateral fixed and dilated pupils. Okay, I'll tell you why this happens. Cerebrophoresis when the MAP is equals to the ICP, and I talked to you about this last point. Hemorrhages happen because of the high ICP. Okay, the blood vessels are sheared, and they are known as direct hemorrhages. Okay, I think there's for it, but yeah, I need this. Just remember, there are direct hemorrhages that happen in the brainstem because of high ICP, shearing of the blood vessels. Now, why does this happen? Okay, now, okay, I'll explain this and explain that on this slide right here. How many oculomotor nerves do we have? Two. Yes, we have two. No, we have two oculomotor nerves. Okay, one on each side. Remember? So let's say, and they sit right here, almost right here. This is where the oculomotor nerves are. Okay, where my cursor is pointing. Now, if you have really high ICP, this oculomotor nerve will be compressed. Let's say the ICP that is high is caused by a tumor that is present, let's say here. Okay, this is a tumor right here. It's causing high ICP. It's compressing on the edema is compressing on the cranial nerve number 3 right here. Okay. Now what happens if the cranial nerve number 3 function is suppressed, which means the pupil will be fixed, right? And dilated. Why dilated? Because cranial nerve number 3 supplies the parasympathetics to the pupil, and the parasympathetics constrict the pupil, right? If you have abnormal parasympathetics, your pupil will dilate and it becomes fixed. Why does it become fixed? Because the cranial nerve number 3 is not working anymore to constrict or dilate the pupil. Now, initially it happens only ipsilaterally, right? Because only on one side. But when the brain pressure, the intracranial pressure becomes too high, the other oculomotor nerve also starts to become compressed. And that's why in the end you get bilateral you get bilateral fixed and dilated pupils. Okay. All right. Okay. So this is the vicious cycle that I talked to you about, right? Let's say you're hypoxia, and hypoxia, as you know, is another cause of cytotoxic injury. And cytotoxic injury will lead to cytotoxic edema, and that'll lead to more edema, more swelling, more ICP, and the visual cycle continues to happen. Is this clear? What part do you want me to repeat exactly? Sorry, I couldn't see it in time, the chat. Do you want me to say the thing about the oculomotor nerve, Nurala? Oh, okay. It's very simple enough to understand. Okay. Initially, only one side might be affected because that's where the edema is happening, right? That's where the compression is happening. But later on, the edema becomes so high that it affects the things on the both sides. That's exactly it. Initially, it's ipsilateral dilated pupil, then it becomes bilateral. When it becomes bilateral, this signifies this is something severe happening. Okay. Right. Let's talk about herniation now. Okay, there are different types of herniation. Before I talked about, these are the different herniation syndrome the doctor has put in, but before I talk about this, I would like to talk about, I've added images just to show you a few things. Okay, what is this? This thing that I'm pointing at, this big fold of dura mater. Excellent. This is Fox cerebri. Very good. What is this fold of matter that I'm pointing at right now? That is horizontal. Tentorium cerebelli. Very good. Excellent. Very good. Okay, so you guys know. So this is the Fox cerebri. This is the tentorium cerebelli. Okay, next. What is this? In green. What is highlighted in green? It's called the uncus. Okay, this portion of the brain cortex Foramen magnum. Very good. So it's called foramen. Okay. Very good. Okay. So if you guys know these basics, we can move on to the different herniation syndrome. And I would rather explain this on this slide than the doctor's slide. Okay. So what is right here in the center? The matter that we talked about here. What is this? Yes, very good. Okay, so this is the falx cerebri, right? This right here is the falx cerebri. So, okay. Now, if because of any increase in intracranial, now remember what did we say about initially that, you know, when increase intracranial pressure, if it's very severe, what can happen? The brain tissue might get displaced, right? It's almost like you are, you have like let's say 2 compartments, okay, and they're connected to one another, okay, and then and they're filled with fluid. If you compress on one, the fluid will shift to the other side, right? Wherever it can find space. And this is exactly what's going to happen with the brain parenchyma. Because of the high ICP, let's say because of this hemorrhage right here, it causes high ICP, right? This is what type of hemorrhage? This is subdural, epidural, just based on the picture, just something extra. You guys might need to know this for exam. This is epidural hemorrhage, right? Because of the biconvexity. So, did you guys take this? Lens shape, yeah. So this is epidural hemorrhage. You guys, it's very important that you guys revise the types of hemorrhages, by the way. Anyways, so this epidural hemorrhage causes increased ICP because it pushes on the brain parenchyma, and wherever the brain parenchyma can find space, it kind of goes towards that. What is this? This is called falx cerebri, right? So what the herniation underneath the falx cerebri would be called? Sub, because it's below, falcine or falcine, I don't know how to pronounce it exactly, because of the falx cerebri. So sub, falcine, brain herniation. This is the first type of herniation that I want to talk to you about. Is this clear? Subfalcine, falcine. Next, what do we say this thing was? The uncus. Very good. Let's say the uncus herniates across this thing right here. What was this thing? This horizontal fold of dura mater. What was this? The tentorium cerebelli. Very good. So if the uncus herniates across the tentorium, we can call it uncal herniation, or we can call this trans, because it's across, tentorial because it's across the tentorium, herniation. Is that clear? So transtentorial herniation. This is the second one. Okay. Next, we have central herniation. Basically, it's almost like, it's also a type of transtentorial herniation, but instead of just the uncus herniating, the diencephalon herniates, which is basically the thalamus and hypothalamus. It herniates vertically downwards. That's central herniation. Okay. Next, we have the tonsillar herniation, which I will explain to you on another image, but this is extracranial herniation. Okay. So tentorial herniation is going to be this one right here. So this is the cerebellum, cerebellar tonsils. Cerebellar tonsils can go through the foramen magnum, and this can cause tonsillar herniation or foraminal herniation. Foraminal because this is the foramen magnum. Okay, so we talked about subfalcine. It's also called cingulate herniation because this is a cingulate gyrus. If you look at a sagittal image, this is a cingulate gyrus right here, and this is the one that herniates. Transtentorial can be either uncal, which is shown here, or central, which goes vertically downwards. Foraminal is tonsillar, and calvarial is extracranial because of, let's say, a skull fracture. Skull fracture, extracranial, outside the skull cavity. Okay. This is transtentorial herniation, which can also lead to direct hemorrhages because of the shearing of the blood vessels. Herniation is not necessarily because of edema. It can also be because of hemorrhage. Just remember this. Herniation can be because of any cause of increased intracranial pressure. Okay. So if you go back and see this slide, when he said this is what increased ICP can be because of. It can be because of tumor, edema, hydrocephalus, or hemorrhage. All of this can lead to high ICP, and high ICP can lead to herniation. Okay. Okay. Is everything clear so far? All right. Now I'm going to talk about idiopathic intracranial hypertension, also known as pseudotumor cerebri or benign intracranial hypertension. I guess these terms, the latter two terms, are not much in use anymore. So we're just going to call it IIH, or idiopathic intracranial hypertension. Okay. So just to give you a quick overview of idiopathic intracranial hypertension, is just remember this: increased ICP with no obvious findings on imaging. Okay, increased ICP with no obvious findings on imaging, which means the ICP of the patient is increased. The patient is exhibiting signs and symptoms of increased ICP, which we will talk about later on. But if you look at the imaging, if you look at brain MRI, there's no tumor, there's no edema, there's no hydrocephalus, there's no hemorrhage, there's nothing. Okay, that's why we call it idiopathic, no cause identified, intracranial, when it's intracranial hypertension because of ICP is increased. Okay, so idiopathic intracranial hypertension. So symptoms of idiopathic intracranial hypertension is almost very similar to the symptoms of increased intracranial pressure that we discussed earlier on. They have a headache, they might have vomiting, they might have nausea, they might have papilledema. Papilledema is more of a sign than a symptom, but we'll talk about that later. So they can have headache, they can have tinnitus. Tinnitus is a ringing sensation in the ear. They can have pain in the neck, shoulders, or arm. They can have pain in the neck because of the irritation of the meninges. Okay, transient visual obscuration. We'll talk about papilledema, and then we will talk about why they might have visual problems. Same goes for blurred or distorted vision. We will talk about that later on when we talk about papilledema. Field constriction. Basically, the field of vision is constricted. Okay, they might get tunnel vision because of compression on different components of the optic pathway. Then we can get diplopia, okay, because of compression of a certain nerve. We will talk about that as well when we talk about the signs. And sudden visual loss, again. So as you can see, most of these symptoms are visual symptoms, and then we can have headache and tinnitus and maybe vomiting, okay? So are the symptoms clear? There's not much to explain here except the fact that, there's high ICP, which is causing all of these visual problems and headache and tinnitus. Clear? Okay. Now the signs. This is important. Okay, this is where we'll discuss some of the stuff. Papilledema. Let's discuss papilledema first, and we'll come back to this slide to discuss field constriction, visual acuity, and abducens paresis. So, papilledema. Okay. I don't know why he has included all this stuff here, but this is including this image kind of advanced for your stage, but let's discuss it anyways. If you look at the retina, okay, if you look at this is the retina, you don't have to know this, by the way, okay, this is ophthalmology. But if you look at the retina, it's made up of almost 11 layers, okay? And the second layer right here, as you can see, this is the nerve fiber layer. This is where the nerve fibers, nerve axons are. Now, because of high ICP in idiopathic intracranial hypertension, what can happen is that the nerve fibers, which include, exoplasm or cytoplasm inside the axons, cannot drain. It cannot, go backwards. And so it starts to accumulate in front. And this is why you get elevation of the nerve fiber layer. The nerve fiber layer elevates. It goes up because the exoplasm, which is basically the cytoplasm of the nerve in the nerve fiber layer, cannot, you can say rotate properly along the nerves because of compression, because of the high ICP. And so the nerve fiber elevates, nerve fiber layer elevates, and this shows you papilledema. If you look at this fundoscopy image right here, this is your macula, this is your optic disc, okay? Optic disc is where, this is basically the optic disc where the optic nerve exits the retina. You see, there's elevation seen here. You will learn more about this in your next block, which is head and neck. But you can see this elevation. There's obscuration of the margins between the optic disc and the rest of the retina, which is known as papilledema. This, I believe, he is shown here as well, very clearly. Look, obscuration. The optic disc seems to be elevated. Okay. Of course, you cannot appreciate this unless you have seen normal images, but just take our word for it. This is elevation of the nerve fiber layer leading to papilledema. Okay. Now, advanced stages can also lead to hemorrhages and cotton wool exudates, venous tortuosity, which you can see some of this here as well. But again, I think this is a little advanced for you guys. I think importantly that you should know only that increased ICP can lead to papilledema. Okay. Is this clear? Now tell me something, guys. Is papilledema because of high ICP going to be unilateral or bilateral most of the time? Exactly, it's going to be bilateral. By definition, papilledema is bilateral swelling of the optic discs because of increased intracranial pressure. Okay. All right. So this is papilledema. We discussed that. I believe it is clear. Any question regarding papilledema? I guess not. Next, we have visual field constriction. Did you guys take the optic pathway? So we have the retina, we have the optic nerve, then we have the optic chiasm, then we have the optic radiations and the occipital cortex, all of that. Did you take that? You should have taken it in neuro. Anyways, so if you see this image right here, this is your visual field. Okay, and because of high ICP, it can compress on certain components of your visual pathway. And here we can see that there is problems with the visual field. There's blackness right here. Okay, 1 second. All right. Then you can have changes in the visual acuity as well because of the retina is affected, right? So visual problems, papilledema, visual field constriction, visual acuity. Let's talk about abducens paresis. Which cranial nerve is abducens? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, or 12? 6th, very good. So the cranial nerve, you should know something about the 6th cranial nerve. It's kind of a special nerve that it is, when you see 6th cranial nerve palsy, you should start expecting increased intracranial pressure, okay? Classic sign of increased intracranial pressure is abducens palsy. And the reason that happens, if you look at this abducens nerve, 6th nerve, is very much involved in high ICP because it's right against the petrous bone. Okay, the petrous bone is part of the temporal bone. I believe you will take more of this in your head and neck. But yani, it's a part of the skull. It's a bone in the skull against which the abducens nerve is running along. So if you have high ICP, this small nerve can easily be compressed and can lead to abducens palsy. Now tell me, what muscle will be affected in abducens palsy? The lateral rectus, exactly. So you get horizontal diplopia. Diplopia is double vision, okay? And because your lateral rectus is not working, let's say that your left abducens nerve is involved, right? So everyone just imagine with me, your left abducens nerve is involved, your left lateral rectus is not working. So when I look left, I have a bit of a problem, okay? My left eye will not be able to look left, but my right eye will be able to look left. And so I get this sort of double vision, which is known as diplopia. Okay, you will learn more about this in heavy details in head and neck block. So for now, just know it's diplopia because of lateral rectus problem because of 6th cranial nerve palsy. Clear? Okay. Now, CSF studies. So let's say for whatever reason, you have high ICP, you want to take a CSF sample. After, usually when your CSF ICP is really high, you really cannot perform a lumbar puncture after you have ruled out some of the stuff. And this in 5th year, you don't have to know it for now. But let's say for whatever reason, you obtain a CSF. First thing you want to know at the CSF is the opening pressure. Basically, the opening pressure is very much indicative of your intracranial pressure. Okay, if opening pressure is high, which means your intracranial pressure is probably high as well. You will look at the cells, WBC cytology. Why would you look at WBCs? In meningitis, these might be increased. Meningitis can sometimes lead to high intracranial pressure if it can lead to encephalitis, which is inflammation of the brain parenchyma, okay? Or if there's an abscess, right? RBCs can be increased because of hemorrhage. Cytology can look at tumor cells, malignant cells. So a tumor can shed some of his tumor cells into the CSF, which you can pick up in a CSF LP. You will look at the protein, sugar, electrophoresis. All of these, protein and sugar, are important for meningitis. Electrophoresis. Why is electrophoresis important for CSF? This is something from another lecture, but I just want to quickly revise it. 2 words. Excellent, very good. Ahmad Nizami, multiple sclerosis. What are you going to see on electrophoresis of MS? Oligoclonal bands. Very, very good. Excellent. Very, very good. You guys are revising, mashallah. Okay. So microbiology, gram stain, acid-fast bacilli, which is Mycobacterium tuberculosis, culture, cryptoantigen, the crypto is basically cryptococcus, which is a fungus which can cause really, basically this slide is telling you what studies will you do on a CSF sample that you obtain. You will look at the opening pressure, you will look at the cells and microbiology. Have any, you should look into other diagnoses because it's idiopathic. We have an identifiable cause, we treat that cause. In idiopathic intracranial, we do not have a because of the high even fenestrate to almost treat idiopathic intracranial hypertension if they have visual problems. So again, I told you the treatment so you can correlate it to what's happening on the CT image, but it's not important. Okay. Honestly, I'm not sure why he included cerebral venous thrombosis here, but I've read that CVT or the delta sign. I'm not honestly sure what the delta sign is. Yeah, so whatever he said, just know it. Okay, I do not think that this is very high yield either. Right, criteria for diagnosis. If it has to be idiopathic intracranial hypertension, there have to be signs and symptoms of ICP, and we discussed all that earlier on. A normal neurological exam. What does this mean? The patient should not have any weakness. The patient should not have any sensory loss. The patient should not have any of the abnormal neurological findings that may point to another problem. Okay, such as a tumor or a stroke. There should be no mass lesions, no abscesses, no tumors. Okay, no AV malformations or no hydrocephalus by imaging. So imaging should be clear. Confirmed high CSF pressure by LP. So when you perform an LP, you look at the opening pressure, it should be high. Okay, CSF composition should be normal. So as one of your colleagues, who was it? Sarah mentioned, if any of these lab tests are abnormal, it's best if you not call it IIH. It's probably something else. Venous thrombosis is ruled out. Okay, so when you have all of these present, you can call it idiopathic. The parenchyma, so they could be obstruction to this level right here, which can lead to the high intracranial pressure. But these are proposed mechanisms of why the ICP is high in idiopathic intracranial hypertension. So this is the pathogenesis, basically. You can think of the slide as the pathogenesis of idiopathic intracranial hypertension. This is the cerebral venous drainage and talking about the arachnoid villi, which are right here. Okay, arachnoid villi. These are risk factors of IIH. I will type this down in the chat. There's a mnemonic which you can remember. I don't know how I can. Okay, everyone. So it's called female toad. Okay, so females, just note this down, guys. So females are at higher risk. T stands for tetracyclines, which are a type of antibiotics. They're associated with idiopathic intracranial hypertension. O stands for obesity. So remember, like fat females are at high risk of idiopathic intracranial hypertension. The A stands for vitamin A excess. Vitamin A toxicity can also lead to idiopathic intracranial hypertension. And D stands for danazol, which is something to do with hormones. Okay, so these are some of the risk factors for idiopathic intracranial hypertension. Female, TOAD. T stands for tetracyclines, obesity, vitamin A excess, and danazol. There are some of the other ones that he has mentioned, such as the menstrual irregularity or the reproductive age group, which you can think of them as hormonal problems, which can lead to idiopathic intracranial hypertension. Is this clear so far? These are just risk factors. Just think of a fat female who is having menstrual problems. Okay, if you can think of this female in your mind, have an image, you can never forget the risk factors of IIH. In IIH, the CSF finding, yes, that is correct. Just the opening pressure will be normal, but the rest of the findings should be normal. The opening pressure will be high, but the rest of the findings should be normal to call it IIH. Okay. All right. Okay. Now this is what I was talking. This is what I wanted to talk about: the Cushing reflex, or the Cushing reflex, because of high ICP. Now this explains some of the signs that we mentioned earlier on, such as bradycardia, hypertension. Why are Cheyne-Stokes breathing? Why does that happen? Let me tell you why. Whatever cause of high ICP, it causes a high ICP. Now what happens when the ICP exceeds the mean arterial pressure? You get cerebral ischemia. Your CP, I said, that activates the sympathetic nervous system. When you activate the sympathetic nervous system, you get increased heart rate and increased blood pressure. This increased blood pressure right here is actually a compensatory mechanism to overcome the high ICP to maintain cerebral blood flow. But over time, of course, as we know, this fails. But for now, just remember the activation of the sympathetic nervous system will lead to the hypertension, okay, and also increased heart rate. Now, when you have hypertension, if you remember cardiovascular physiology, the hypertension will activate the baroreceptors, like the carotid receptors that we mentioned earlier on. If they activates the carotid receptors, that will activate the parasympathetic nervous system to decrease the heart rate. Okay, so we get bradycardia. Okay, now next, the hypertension itself present on the respiratory centers to have this irregular patterns of breathing. So you get this Cushing triad, which is hypertension, bradycardia, and irregular breathing. And this is the pathophysiology of it all, which is the classic triad for increased intracranial pressure. Now, this is the end of the lecture. Is everything clear so far? Oh, he sets a line about treatment. I'll tell you a little bit about treatment. You treat idiopathic intracranial hypertension with weight loss. You can treat it with diuretics to get rid of the excessive fluid. You can do the optic nerve surgery that I told you about. You can do CSF shunt. You guys, I think you should know what the CSF shunt is, just to relieve the high ICP. But again, you do not have to know for the intervention, so don't worry about it too much. But I believe this was a, what do you want me to repeat, please? The question. Oh, sure. All right. I know some of the stuff here in this reflex is a little counterintuitive. Sometimes doesn't make a little bit of a sense, but try to get the big picture here. Okay. First thing you have is high ICP. High ICP leads to cerebral ischemia, and we know why that happens. I'm not going to explain it again. Cerebral ischemia will activate the sympathetic nervous system. When you have the sympathetic nervous system activated, you get hypertension because of the activation of alpha-1 adrenergic receptor, which causes systemic vasoconstriction, leading to hypertension. Clear so far? Now, remember when you have high blood pressure, what happens? Your baroreceptors get activated, which are present in your aortic arch. They're present in your carotid bifurcation. These baroreceptors, once activated, will activate the parasympathetic nervous system to decrease the heart rate. This is why you get bradycardia. Okay. Now, hypertension itself is also known to press on the respiratory centers and causes abnormal pattern of breathing. So this is the Cushing triad: hypertension, bradycardia, and irregular breathing. Yes, of course. You can take a picture of it. You can, yeah, I will send Zuhaib the slides. Okay. For the review lecture, I hope you guys enjoyed, and I hope you cleared out some of the misconceptions that you had. If you have any questions, feel free to type them in the chat.
I think there are no questions.
Oh, great, perfect.
Thank you very much, Safwan.
Thank you, Zohaib. Thank you for coordinating. Thank you, everyone, for attending. Take care and have a very good exam, inshallah.
Thank you very much.